take it out.
Why did you take good care?
Hi, Raji.
Hi.
Hi. So you're going to end up this is the session that you'll end up the
Cases. Yeah.
the unknowns to, right?
Yeah. It's going to be a long session though. In morning it took 2 hours.
Oh, okay. So all right. So I will be coming and going in between.
Okay.
So okay. I'm making you host again.
Sure. Okay.
Yeah.
Works. Okay. Thank you.
So now you can admit people.
Okay. Hello, everyone.
Hi.
Hi. So let's give a minute and then we can start.
Missed the discussions for last few weeks.
Sorry, I only heard half of what you said. What are you saying?
I was just saying that I missed the case discussions last few weeks. Feels like it's been very long time.
Oh, really? I actually didn't have anything after Monday, I think. I don't know when I had cases. Akanksha was doing reading sessions, but I don't know when.
Yeah, I missed those sessions, that's why.
Right, yeah. I was on service too. I couldn't attend all of them either.
Okay.
Okay. People who talk are here, but there are no listeners today, I think.
Today's cases are tough. I think people are scared to join in.
I mean, I don't blame you, but I thought to end it like this would be better.
Definitely.
Yeah.
Well, I haven't looked at the cases, but I'm ready for them.
Okay.
Well, it's,
Raji,
I mean,
you will have
it's
to admit people. I think Amber is saying that she is trying to admit, trying to come in.
I don't see anybody in the waiting
So
room.
if you go into participants, I mean, you might see people admit.
Yeah, I admitted these people, but I don't see her here.
Maybe make me co-host and I'll see.
Okay. How do I do that?
Go into my account and click on the right hand side. You will see make co-host.
Hold on, let me stop sharing 1 second. And then... So where is my account usually? Which part of the screen?
So no, you would go into participants and then my name.
Okay. Oh, and then more make co-host. Yeah, okay, I did that.
Got it? Okay, let me see who is. All right, let me message in the group. Join again. Hi Shweta, hi Priya, Halima, hi.
Hi, everyone.
Hi.
How is it going for you, Akanksha, after the move?
Oh, don't ask. Has been a nightmare, but not that bad. I mean, the previous moves were bad, but this move is okay.
Is it a new job that you've changed, or is it just the houses?
No, I changed the jobs. I initially was living 2 hours from my husband. Now I am living the same. I mean, I'm working the same hospital as my husband. So
Oh,
I
that's cool.
changed the states.
Okay, okay. Wow, that's nice.
Yeah.
Congratulations.
Congratulations.
Yeah, right.
Yeah.
That's weird. I mean, I wonder, I mean, that's weird that we have only the speakers today.
Yeah. Okay. So shall we get started then?
Yeah, I guess so. I mean, I tried to type Amber, but I don't see her in the
Meeting
waiting.
room. Yeah.
Yeah. Okay.
Okay. Maybe as we go, people might join.
Sure. Yeah.
Okay. Who
Okay.
wants this one?
I can take it.
Okay,
Uh,
Shweta, go ahead.
Okay. I don't know exact answer, but I think I was.
It's okay. It's okay. You don't have to know the answers for any of this. Just go ahead.
Okay. Well, there were few on which I was clueless. Which lineage is this going? This one, at least I know the lineage.
Okay.
Okay. This one is like we are targeting that pink population, and behind the pink population, there is another blue population, which will
Right.
separate out later on.
Okay.
So this is the population that we are after. So this is CD19 positive, moderate, bright population, which is lambda restricted. And if we see that blue population is somehow going into that kappa side over here.
Okay.
There is on next plot, they are one is 5 positive and another is 5 negative. It will show up later on, like more clear, I think, in some other plot. But they are both 19 positive. For now, we can just say it is 19 positive for that.
Okay. Okay.
And then it is both are kind of 38 negative, 10 negative. 200, I would call it maybe subset positive or maybe negative. I wasn't
Okay. So a partial subset
partial
positive.
positive. Yeah, I was there. So 20 is again positive, moderate positive. I would say moderate to bright. And then again, CD5 pink population looks like there has some CD5 expression. The blue does not have a CD5 expression on it. And then 38 is negative, again 10 negative. Then it's the pink population is lambda restricted, and the blue population to me is kappa restricted.
Okay.
So I was thinking of like it is an abnormal biclonal B cell population. One is CD5 positive lambda restricted, and another one is CD5 negative kappa restricted. So
Okay.
that's where I was on it. Yeah.
So
Though
you're
that
right.
5 is a diagonal position, but I still think it was kind of positive. I mean, I was thinking half of the population to be positive. Yeah.
Okay, so you're right. This is a biclonal B cell population, and actually, this CD5 is also positive, but I wouldn't blame you because it's kind of hidden behind here. If you look at here, even in this side, you will see some dots. I mean, but we had some histograms, so that was easy to see. But in the dot plots, it was not possible to identify. So I mean, it is a biclonal process, and they were positive for CD5 and 200. 20 was dimmer, and the light chain expression was also dimmer compared to the normal B cells in the back.
So then it is biclonal CLL then, right?
Yeah, it was a biclonal CLL, but you don't have to say that.
Okay.
Right, but it was a biclonal CLL.
Okay.
Or it could be a
was
biclonal
confused by that
MBL
5
also.
positive and 5 negative. I've never seen like it CLL like one which loses 5, another one has it, and in the same like.
Right. Yeah. They usually have the same phenotype, and only kappa lambda would be different.
Yeah.
Yeah.
Okay.
That's how it was. Okay, straightforward. Okay. Any questions? Okay. Next one. This is an enlarged lymph node.
I can try this one.
Okay.
Okay. So we have blue population, 45 positive, low side scatter, and then it looks like it's the blue population is there is like 20 positive, 10 negative, 34 negative, and then we have, I think there's a subset that is kappa positive, and then another subset is lambda positive. And there is a little, I think there's a little bit skew toward lambda. There's more lambda than kappa. And then so 20 and 10 is just looking at those cells, and they look like kind of a, they look like there's more lambda than kappa. So probably it's just, it's not there, nothing much there. They're 71 negative. Then this population, then this one is looking at the B cells and T cells. B cells are 19 positive. Our T cells is 5 positive. The B cells are partial 23 positive, FMC positive, 200 negative, and 5 negative. And there's more lambda than kappa. And here again, the 19 positive, 5 positive is just showing, I think, more lambda than kappa, whatever the gate grabbed. Nothing more, nothing special. And then here it's looking at the T cells, which have high site scatter, higher, 45, brighter 45, and they're green here. They're 3 positive, 7 positive, 5 positive, 2 positive, 4 to 8 ratio looks normal. And then they are, and there are 2 positive, 7 positive, we said. So I thought this was a reactive lymph node.
Okay, so your description is right, but the kappa lambda ratio is really off, and it's 12 to 15 or 11 to 50, which is like 1:4 kappa lambda ratio in the favor of lambda. That is like very abnormal. The normal kappa lambda ratio should be somewhere between 0.8 to 2, or sometimes 2.5, more in the favor of kappa. Usually kappa is a little more higher than lambda, or usually they are like in the 1:1 range. If it is a reactive lymph node, even in reactive lymph nodes, kappa predominance is something that we often see. And also like reactive lymph nodes will have some 10 positive cells, 71 positive cells, 38 positive cells. We don't have to necessarily see that, but even if we don't see it, it's more, in the favor of kappa. Seeing a lambda predominant population is not normal, and whenever we see that, we have to definitely raise an alarm in our diagnostic report, saying lambda predominant B cells correlate with morphology to rule out lymphoma. This one was a marginal zone lymphoma. So like in marginal zone lymphoma, we don't see any 5 positive or 10 positive B cells or any other clues. So if it is kappa predominant, sometimes we easily pick up. Sometimes you will see a difference in intensity in CD20 or CD19. This one might have a little bit of that. There are background polyclonal lambda cells, and then this probably has a little dimmer CD20 than the background, but it's too subtle, hard to identify. Here, the major clue is having such a high kappa lambda predominance. So we should definitely raise an alarm when we see this. And in our top line, some people even say lambda restricted monoclonal B cells. That usually is retrospective. They have both the flow and the lymph node with them, so they say that. Or at least we have to say lambda predominant B cells and say correlate with morphology.
Okay, I was thinking because they're polyclonal, they're polyclonal. That's what I was thinking.
Right, so there are some background polyclonal cells here. You're right, there are polyclonal cells in the background, but also it's a monoclonal population.
Okay.
Yeah, it's just not separating out very well, and it happens sometimes. But when you see like very high kappa lambda ratio or lambda predominance, you have to think about it.
Okay.
Yeah. Okay, and this is very often missed by a lot of people actually, when it is lambda predominant with no definite clonal separation.
Clonal separation. Okay.
Okay, case 3.
I can try it, but I was
Yeah.
clueless. This is the one I spent a lot of time when I was like scratching my head. Okay.
Okay.
I wasn't even like getting into any direction with this. It's maybe I'm missing out something. Anyways, okay.
So step by step, okay?
Sure.
Yeah.
Okay.
Yeah.
So this one, yeah, on this plot. So I was concentrating on two population. One is that dark blue population that is to me is in falling in the blast area and kind of merging up with the grands. It's not that discrete population over here. Second, I think that blue population, I thought it's a lymph, but just like I wanted to like B lymphocyte, it's falling in that region, but I wanted to just follow on it.
Okay.
So uh, so here, so both of these populations, they were 19 positive, and as we were expecting, those B, if they are B lymphocytes, they are 19 stronger, and these if these are blasts, these are 19 positive blast. Their 19 is not, I won't call bright, it is moderate to me. It's like moderate positive.
Agree.
Yeah. Yeah, and then kappa to lambda is negative on these 19 positive cells. So they are kappa negative, lambda negative. So we have to think of some kind of like immature cells on it then. And then even those, it's hiding, those blue population is hiding behind, but maybe they are kappa, I'm not sure, or if it's hiding. Okay, anyway.
We have a better plot later. So
okay.
Yeah.
Okay, and then it's here, it's like this is 19 positive, and that blue population is 5 positive to me, yeah, and it showed later on too. And then I was thinking of that blue to be, maybe can it be hematogons, because they have like very low kappa to lambda even if it is there, and then there is some 5 which may appear in later mature hematogons, you know. I was thinking on that direction for those blue ones, lighter blue ones, but let's concentrate on the darker blue for now. So darker blue is 38 is positive on it, it's moderate positive, and then the light blue is 38 negative. They both are 19 positive, as we know by now. The dark blue is 200 negative, and then the light blue is 200 positive. And going next, yeah, so even this blue, light blue population is kind of showing a smearing on 20, that again like kind of made me think, is it like kind of trying to mature towards, because that red and green is the mature B cells, kappa lambda kind of B cells. So I was thinking of, is it kind of maturing cells? So I was thinking like this light blue is very immature cells, sorry, dark blue is very immature cell, and then this lighter blue is kind of trying to mature, and then that red population is mature cells. So that's where I was with that. So okay, and then yeah, this blue had some very dim, if we call it maybe kappa positivity, if any, is positive here then. And then there are 5 positive over there, and our darker blue population is not showing in any of these two plots. So those are definitely very immature cells.
Yeah, how did they actually disappear, the dark blue population in those?
Because they do
It's
not
taken
express
out.
kappa lambda. Oh,
They
and
were
then in
taken
19,
out,
I don't know why they disappeared.
subtracted.
Yeah, it's just taken out. Only this population is strong.
Okay. Okay, yeah. I was assuming that that blue, dark blue population is becoming, is it the same, this
Yes,
red
the
population
maroon
over here?
population. Yes,
Yeah.
it's the dark.
So I was thinking, is it the same? Because 19 then can, like with 19 positivity, you have to think of two things. Either it is a, like think of either it's BALL side or it's an aberrant expression in myeloids.
Right.
So those were the two things that I was like on it for it. So then it is like 34 is expressed on them, and their side scatter is low. Then going on to the 34 versus 34 is positive, and then 38 is also positive on it. And as they mature, they're 30, like these fluorescent green are like granulocytes. So it's kind of following the pattern for maturation as it should, I think. Then on the next plot, this population is to me expressing some 56, though it is at the level of mature grands, like I would say, I don't know.
No, there is
Maybe
some expression.
there is some expression.
Yes.
Okay, then 56 is there. That is aberrant expression.
Right,
So
right.
that is there. 15 is definitely negative. It's further like kind of helps us say it's not that mature. And then its HLA-DR is positive, and as it is maturing, it is losing HLA-DR, which is fine. Then is 123 is negative. So we are ruling out dendritic or basophil, like those from that line. 7 is to me is negative. 117 is to me is positive, and it's kind of following the pattern as it should. Yeah. And then where this was the grand.
Okay, so you want to follow the blast first and then come back to that one. Yeah.
Okay. So this one, yeah. So here, so here these.
What's the
red
source of the specimen?
Bone marrow.
Okay.
So yeah, so I think here it's like that pink population is the stem cells, and then there are blasts, and then green is like maturing granulocytes are there. So this population is 45 moderate positive. I'm dealing with this red maroon population, and then this population is 11 B negative. Okay, and then it's. Did I it's a train? Okay, so it's 13 is there, and I'm just trying to follow the pathway. I think it is
Go ahead.
fine.
You're good
It's
so
fine.
far.
Yeah, so it's yeah, to me it's like 13 is fine. It's there, and then it dips, and then it rises, kind of. Yeah, and then 33 should be fine. Yeah, looks like fine to me, and then 14 too.
No, what do you mean by fine? You mean positive or negative?
Sorry. So 33 is positive to me. Sorry, I should say that. Yeah. So
Okay.
11B is negative, 13 is positive, 33 is positive. So it is showing
Okay.
some myeloid markers to it. Yeah.
Right. Okay.
14 is negative.
Okay.
And then it is 64 to me is negative, and then HLA-DR is positive, and then 10 is again negative. I was trying to see like maturation patterns. That's why I was slowing down. Like, is there any dysplasia, which I most of the time is. So I was going on that line, but forget that. I do not see that. I think they're going fine. And its expression is like, so far we see 19 is expressed, and some of the myeloid markers like 13, 33 DR is expressed on them.
Okay.
Yeah. Now going back to these grams.
We also had 117.
And we had 117, so it has like those myeloid markers to it.
Okay.
So it is most likely a myeloid with 19 expression on it,
Right.
like Abram 19 on it. Now going on to these, in this one, this looks like 13 and 16 plot looks normal maturation to me. 10 is normal to me. 1610 is normal maturation to me. To me, I wasn't sure about 33 and 13 plot. It usually, what I was told, like it should have a dip and then go up. So I didn't see that dip on it, like on maturation for 1333. So that was the only plot I was concerned, but the rest of the other plots, I thought the maturation was fine.
Okay.
And here the blasts are kind of merging with the grans. This is also something like not normal to me. Like they're not that discrete. It's kind of like, they are merging into them. So yeah, to me it was kind of an acute myeloid leukemia with aberrant expression of 19 to it. And
Okay.
if that 1333 is abnormal, then there is some maturation, dysplastic changes too then.
Okay.
Mhm.
Anything else? So
No.
you.
Sorry.
Yeah.
No, I just wanted to say, for me, when I was looking at those green plots for the granulation, the granulocyte maturation, I just felt that 13 and 16 didn't look right to me, because I thought there was less 13 that there should have been. So the check was not entirely how it should be. I thought, and then 33 and HLA-DR. I was looking for an inverted C, 33 and HLA-DR.
Oh yeah. Mm-hmm.
But I didn't see it, and I felt like if the light green is reflecting mature granulocytes and the dark greens is reflecting immature, there's a lot more immature than there is mature. So I thought that there must have been a dysplasia happening with the maturation, grans maturation, and then And yeah, so, and then I thought that the blasts had the aberrant expression of 19 and 56, and maybe that 19 is like a subset of blast that is just like separating off and aberrantly expressing 5 and 9 and 19. So I agree with Shweta that it's AML, looks like an AML with dysplastic changes.
Okay. So we all agree with AML, and I agree with AML. So let's go over the plots. And the reason I gave this table was because I wanted you to see how many progenitors are there in total. So they are like 66%. So clearly it is like a lot of blasts, and it is an acute leukemia. And we do see that in CD45 versus side scatter, we see this dim 45 dim population going with high side scatters kind of merging with the granulocytes. So those are our blasts, and I'll come to this aqua population in the end. And then they have a variable heterogeneous CD19, and they do not have kappa lambda surface light chains, and they're negative for everything else except CD38. They're negative for CD20. They have CD38 expression and CD200 expression partial. These can be seen in all kinds of blasts. They are not specific for anything. And this kind of variable CD19 we don't usually see in BALL. BALL will be like really brightly positive for CD19, and also BALL would be positive for CD10 in most cases. And if you have like bright CD19, one additional marker is enough to call it BLL. And if you have like a dim CD19, then you need 2 additional markers like 79A or 10 or 22, 2 other markers to call it BLL. So we don't really have, this is the only tube that had the B markers, and we only have a heterogeneous 19, no 10, no 20. So we don't really have a B marker to say there is a BLL in this one. So we have already seen what is another tube. It is more like a myeloid with aberrant CD19. So that I agree. And the blasts are CD34 positive, 38 positive, CD56 partial, HLA-DR positive, CD117 positive. So again, myeloid, negative for CD7, and no monocytic markers like no 11D, no, partial 64, but you need 2 monocytic markers to actually call it monocytic. So no 14, and then DR is partial, and 13, it has a partial 13, and it is positive for 33. And again here no 10. So it is an AML, and this kind of 19 expression we usually see in 821. So again, those blasts have high side scatter, and they, like, some of them actually are like M3 or early promyelocyte type morphology, right? So they do have high side scatter, and also they might have some dysplasia sometimes. And this 13 versus 16, we actually don't see anything here that has bright 13 but no 16. That's where usually promyelocytes sit. So we really don't see that population here, and we see a loss of CD13 in this population, and that is abnormal. And also, like, there is a left shift with very few granulocytes, and even the intensity of CD10 is not very high in the mature granulocytes. It's less, like again you said in 33, and HLA-DR in 33 versus 13, basically acquisition of 33 is also a little bit abnormal. So 821s do have dysplasia, in accompanying dysplasia, but it's not some always easy to find, because most of the cells are usually blasts, and sometimes you're lucky you'll be finding them. So that's basically what it's an additional finding that I wanted to show in this case. And then the aqua population, it has really bright CD45, and it merges with the lymphocytes with its intensity of CD45. And then if you see, its 19 is homogeneously bright, and it does have a little bit of kappa, and it is clearly positive for CD5, and it is CD20 dim. So it is negative for 10. You can argue it could be blast, but really it is mature. Based on this CD20, you can say that it is immature, but it is actually having really bright CD45, and with the along with the other B lymphocytes. So that was a separate monoclonal B cell population that was coincidentally there along with this major leukemia. So, and it has a CLL phenotype, and This I have seen very often, like a small clone of B cells in AML with monocytic differentiation and 821. At least I have seen 4 cases of 821 with a CLL-like clonal B cell population. I don't know what is the reason for it, or if there is really an association, or it's just coincidence. But we do see this quite often, and that's a separate mature monoclonal B cell population. These are not hematogones again, because there is no 10, or you don't see a trail here of losing 10, and there is a heterogeneous 20 positivity, but in 10 you don't really see anything. And again, there is 5 and 200 positivity, just like CLL. And CLL phenotype usually has dimmer surface light chain. If you remember from the previous case, the abnormal cells were also like dim surface light chain, which is kind of what we see in CLL. Like this is not CLL because the B cells in total are only 2%, but it is it has that phenotype. It's an MBL.
That's interesting.
Yeah, so I just wanted to, I mean, many of these cases, I tried to find cases that had 2 things going on at the same time. So this is one other case like that.
But you still have to mention about the MBL, right?
Yeah, we mentioned it, yes. Okay. Yeah, we mentioned it in the top line, yes. Because we don't know what that was going to evolve in the future as.
Okay.
Yeah. Actually, we once had a case, I was trying to find it for some reason. I don't have that PDF. We once had a case, patient had acute myeloid leukemia. And then there was a small population of plasma cells. We didn't have a separate plasma cell tube, but we saw a population of plasma cells that had CD56 expression and loss of CD19. And then after induction therapy, like after 28 days of induction therapy, when we got the bone marrow, like I don't know exactly, not on exactly 28 days, after 2 weeks after 28 days, we had a plasma cell neoplasm, sheets of plasma cells. So,
Wow.
so we don't know what evolves after the major neoplastic process is eradicated. So
That's correct.
yeah, they get a survival advantage sometimes. All right. Okay, that's this one. Case 4.
I can take it if.
Yeah, sure. Go ahead.
Okay, so here we have a blue population that's 45 dim intermediate with a little bit high side scatter, and they look red. So they're 34 positive, 33 positive, 117 positive, HLA-DR positive, and then they are 15 negative, 38 positive, and then 11B negative.
Hold on 1 second. Okay, network issues.
Okay.
Okay, yeah.
And then, so here there are 71 negative, 3 negative, 16 negative, 14 negative, 64 negative, and then 56 negative, HLA-DR partially positive, 56 negative. So there are HLA-DR partially positive, 2 negative, 4 negative, 7 negative, 71 negative, 8 negative, 19 negative, 10 negative, 20 negative. So all the pan T cell antigens and B cell antigens are negative. Here it's just looking at the monocytes. Monocytes are expressing 64 and white 14. They are 34 negative, 56 negative. They're expressing 11B. They are HLA-DR positive. And so they're 13 positive. So they look normal to me.
Okay.
Then this last one, I thought that this was catching mastocytes. They're bright 117, even though the plots were really tiny.
I know. Yeah.
So I tried to see, and I thought I picked up 25. These mastocytes or these 117 positive cells were 25 positive, aberrant 25 positive, but they're negative. And then I think they were expressing 33 or something.
Yes.
33. So,
Yeah, that's it
so,
basically.
so I thought this looked like an AML to me with an abnormal mastocytes in the background circulating.
Right. Okay. This is a bone marrow, so it had just had abnormal mast cells along with it. Basically, it was a systemic mastocytosis along with an AML, systemic mastocytosis with associated hematologic neoplasm. So one thing is like, you know, by the time bone marrow flow usually comes first, bone marrow biopsy comes later. And there is a clue to identify these mast cells in your regular panels, because mastocytosis panels are usually add-ons. If you see in these plots, you will see a population here that has brighter CD117 than the blast, like the blast CD117 intensity ends here, whereas you see a population here that is negative for CD34, and you see a population here that is negative for HLA-DR with bright 117, and here it is kind of distinct, 33 positive and 117 positive. So, you know, that kind of gives you a clue, like here it is 38 and 117 positive, that you have to add your mastocytosis panel. Basically, I did
Goodness,
that.
that's a very vague clue. But yeah,
You see it. I mean,
yeah, I mean,
when you see this, you can add your panel. I mean,
How do you differentiate from promyelocytes then? Because I
those
thought of
don't
those.
have this extent of 117. So whatever your blast 117 is, promyelocytes would be actually dimmer than that. They have usually partial 117. They would be sitting somewhere here because they are in the process of losing 117. Mast cell 117, there is no match. Like that is the brightest
is it the
117.
brightest CD117?
Right, it's
Okay,
kind of
okay.
in the edge always. So that would be like brighter even than, see, if you see in this plot, it's kind of very distinct. If you see
That's
here.
the best clue. CD117 bright.
Yeah, and they are 33 positive. Mast cells are 33 positive, and they are negative for HLA-DR and 34. So you won't confuse them from the blast. And they kind of is like quite a difference between the intensity of 117 in the blast and in the mast cells. I wanted to show this one actually. And they were aberrant because 25 was positive and partial 2 is not as, it doesn't always be positive on flow. 25 is more sensitive. So this was SM, AH, and M basically. But otherwise the blasts were clearly myeloid.
Cool.
Okay. Case 5. Who's gonna do case 5?
We can attempt.
Okay. Case 5 is, it is challenging. I agree with that.
Okay, I can try and then.
Yeah, sure. Please try.
Again. Okay, so here, yeah, I did find two populations. So there was a blue one and there's a maroon in the background. I looking at the blue one first, or I can. So here, the blue and maroon, both of them are 19 positive, and they're a little slightly dim intensity than the background B cells, which are bright, like red and green. And then there are the blue and that red maroon population is 5 negative, 30, 38 positive. The red is a little bit more heterogeneous. Blue is more uniform. 38 positive. Then the blue is 10 negative. The maroon is 10 positive. And then both of them are 200 positive. They're 20 negative, 5 negative. Then here, well, I think the dark blue is at the background. Both of them are 34 positive, 38 positive, 56 negative, HLA-DR positive, 15 negative, 123. I thought that purple one were my basophils.
Right.
So based on that, I thought that they were either dim positive or barely negative.
Okay.
So I'll call it dim positive, or but I thought because there were so many of them, that's why they were showing expression. So I'm going to call it negative for now.
Okay.
So 7 negative, and then the blue population is 117 negative. The maroon is 117 positive. Both of them are 71 negative. And then here, the 34 positive. There were like so many colors going on here. I
Yeah.
thought the black, I'm not sure where it came from, but I have the aqua, which is the 10 positive, which is the maroon in the other one. And I felt the maroon.
So basically the okay, right, go ahead. I'll tell you later where the black came from.
Okay, so so there are, both of them are 11B negative, 13 positive. Then one of them is 33 positive and the other one is 33 negative, I thought, or it wasn't showing. It might have been dim. Both of them are 14 negative, 64. The aqua is 64 negative. The maroon one was slightly 64, like it was going into 64 positive, or dim positive. Both of them are HLA-DR positive. The aqua one was 10 positive and the maroon was 10 negative. So then here, I think this one was just showing, I thought these were showing monocytes.
Right.
So the monocytes have 14 expressions. So my orange one are mature monocytes. The pink one are a little bit immature monocytes. So I just found that the expression of 13 was a little bit abnormal for the mature because they're not showing as strong expression. So I thought there was a little bit of left shift in the monocytes. Black, it looks like my like blast population that's being caught up in that gate, in the monocyte gate. And so yeah, I thought there was a left shift for the monocytes.
Okay.
Then this one was just showing, I don't know what the cyto IgG1 are. I think it's
Just like a cytoplasmic control. Ignore that.
Okay, which is
I just wanted to give you a sense of the green is actually just the blast, because the blasts are colored in many different colors here. But the green, the pink, and the blue are all blasts.
blast.
I just wanted to give that idea.
So I think here, I thought the tube was added just to see if we have like a BLL population. And then we have a myeloid blast population. So the blue is MPO positive, and then I thought the purple dark blue is MPO negative and maybe partially cytoplasmic CD79 positive. I think so. That's the last tube, right?
So the blue are just the background granulocytes.
Oh, okay. So they're into
Pink and the blue.
Yeah.
The dark blue and the pink are the blasts. These are blasts.
Okay.
And these are also blasts. Like this blue is blast too.
Right.
But these are also blasts. This is just internal control for MPO.
Okay. So my blasts are MPO negative, and they are showing partially 79. They're showing partial 79. Okay. So based on that, I have no idea. I was thinking early on that it could be, there's definitely probably BALL.
Okay.
In there, because of the 79.
Okay.
And then, I thought, for some reason, because I thought it could be a mixed phenotype. So
okay, that's fair. This is a mixed phenotype.
Okay.
So the only thing that you differ from like what I was going to say is that this MPO, it is not fully positive, I agree, but it does have some positivity. So MPO can be variable, right, in different stages of maturation. Like promyelocytes have the highest MPO, and the neutrophils and myelocytes, they have like 2+ MPO. You don't have to have the promyelocyte intensity MPO to be positive. Like, for example, like these are probably the promyelocyte intensity MPO, but all of these are granulocytes, and the blasts do reach there, and we have the control here, lymphocytes, for internal control. So the blasts have MPO. Not all of them, like at least a subset has MPO positivity, like that of the background granulocyte. So we did call this MPO positive, and we also called this CD79A positive, both in a subset.
Okay.
And then everything else you described was the same thing, like CD13. There is a loss of CD13 in the subset of monocytes. That is not normal. That is something abnormal that we saw. But and also there were increase in immature monocytes. But the blast, like it was not. We didn't have a definitive evidence of a monocytic differentiation in this blast actually, and they had 117. Half of the blast. So let's go from the first. So this is the blast population, and then we have they all have like a heterogeneous 19 positivity, unlike BALL, which would be homogeneous positivity. This is heterogeneous. So when we have like this kind of moderate positivity, we need 2 additional markers, which would be 10 and 79A in this case. So half of it is bright 10 positive, and we also had a subset that was 79A bright positive, and then they are both 200 positive, 38 is kind of heterogeneous in these two populations, 20 negative. And then again in the blast, they are HLA-DR positive, 38 positive, but half of it is 117 positive. The other half is this is the myeloid component, and the other half with 10 and 79A, that's the lymphoid component. And they are all, so here the black is basically coming from the CD10 positivity, and the blue are 117 also negative. That's why we have like all these colors here. But again, here there are no monocytic markers. 33 is variable. They all have variable 13 and 33. Like you said, the brown population or the myeloid component has heterogeneous 33. The others look completely negative. There is no monocytic component. Again, 10, we have 2 populations. And then this one, like I said, half of it we thought was MPO positive. Like you see that the 79A positive blasts are kind of labeled in blue, and they are kind of here. They're negative for MPO, but we do have some MPO positive blasts here.
Okay.
So this is mixed phenotype and B myeloid.
Nice, interesting case.
Thank you. All right, moving on. I'm getting a call. Just hold on for a minute. I'm going to mute myself, and then I'll Okay, let's resume. Case 6.
I can take that if.
Yeah, okay, Shweta.
Yeah, it's fine. Okay, so on this one, on this plot, what was it? That blue population, I think that's what I was thinking of, but
Yes.
other than that, other was fine. So yeah, this population was falling in the blast area.
Yes.
And this population was 19 negative, it was kappa and lambda negative, it was 5 negative. It had moderate to bright 38 positivity, 10 is negative, 200 is negative, and yeah, it's again 20 negative. Okay, here, this blue, lighter blue population, that's what we're targeting at. So it has like some subset has a 34 positivity to it. And then in the next plot, it is like subset is 34 positive, which is 2 negative, and then the other half, there is kind of 2 is positive, like dim to moderate positive, 2 is there, or you can say a partial loss of 2 is there. So only a subset is 2 positive. Again, like there is a subset is 34 positive, and the 34 positive is 7 negative, and then subset is 7 positive and 34 negative. So in the next plot, it is 56 positive. And it will be seen in the next plots that it is 56 positive, and then it is like again 34 positive is 4 negative, but then there is some 4 positive cell to it. So and then 34 positivity again there. And then it's 3 is negative on it, and then there is it was 4 clearly positive, and then 8 maybe some subset. I wasn't sure on this 8 if I should call it positive or not, but maybe dim 8 positive for now.
Okay.
So then this one again, we are targeting that blue population here, which is 38 moderate to bright positive, and then is 56 positive, which is clear over here, 30 and only a minute subset was 34 positive, so which is not showing over here in these plots. Like in 56 versus 34, we didn't see a big 34 positive population
Right.
there. So yeah, and then it's where we are, 15 is negative, and it is HLA-DR is positive. Then it is 123 to me is maybe subset is kind of positive. It's more than the grants that it is going, though it's little lower than the Bezos, but to me it was like kind of damn positive maybe.
Okay.
And then 7 again we did before, and then 117 to me is negative, 71 to me is negative. Where do we go again here? Okay, and then here we are looking at the blue population again. It's falling in kind of a blast area, and then in the plot below, to me that orange is kind of monos, and then this green are the grants over here, and then we are looking at the blue population. Yeah, the blue population is like 45 moderate positive, 11 B is negative, 13 negative, 33 negative, 14 negative, 64 negative, DR positive, and 10 to me is kind of negative. So
Okay.
it's not like myeloid. So we ruled out it's not like myeloid
Okay.
lineage from there. And then it has some T cell markers to it. Then 123 here, it is positive. It's 40. Yeah, so 120. Site schedule.
So
I
this is
don't know
side
why
scatter versus.
it's looking as two populations to me. Like it's in side scatter versus 45. It looks like there is one population which is like very bright 45, and then another population which is like going up, like side scatter, which usually
this
like kind of
one?
a Grant's plot. Yeah,
Yeah,
this
yeah.
looks
These
like,
are granulocytes and lymphocytes, and they are all colored in same color, just to like background cells.
oh, okay.
Just focusing on the blast. Those are all background cells. All other cells are colored in single color. It's safe to ignore them.
Okay, so now we have to look at that dark green then. So,
This blast area has actually 3 populations here.
mhm.
I mean, they have 3 different they colored it 3 different based on 123 and 56 positivity. So we have green, maroon, and blue, all 3 here.
Yeah. So one population is 123 negative, and maroon and red population is 123 positive over here.
Okay.
And then going down, it's like they are there is all of them are 4 is positive on them. So
Okay.
4 positive, 123 positive, and then the subset of it is that dark green is 56 positive. So those are dendritic cells, like 456 and 123 positive cells.
Okay.
To me, dendritic cells. Now, what is that red and blue population there, which is 56 negative and 4 positive, 123 negative.
Oh, this
So,
one. Okay.
yeah. So going down.
This is another tube.
Okay. So yes, the blue population is the grants that they are showing. We are targeting on dark green and red population. So they are showing that they have a 56 expression to them, and MPO is negative on them. And they are when we go to the cytoplasmic CD3 tube, so they have that now they separate out, like there's red population is the T cells which have cytoplasmic CD3 positivity to it, and then there is that dark blue population has dimmer CD3 positive, cytoplasmic CD3 positivity to it. So these are, I think, to me are abnormal, like this dark blue ones, and that light blue is myeloid. So ignore that. But light blue is kind of a control to us. So it's like this dark blue to me has a dimmer expression of 3 to it, cytoplasmic CD3 to it. So there is dendritic cell in the background, and then there is that T cells which have DIMR3 to it.
Okay.
So yeah, and then which plot is these one? I wasn't sure how. Okay, this blue and red population that we have to focus on then. So this blue and red and green population, yeah. So I wasn't sure, is it like sticking off antibodies
Yes.
to it, and then they are looking diagonal and all these,
Right.
kind of appearance. It's like stickiness that is showing up. So I wasn't like making out anything out of these plots.
Okay.
I would
Fair.
say. So like this one is like specifically, these look like they are some sticking, they are diagonal, and then,
Okay.
I don't know. I wasn't sure on these plot, like where exactly is it going?
Oh, why 42B, 4161? All these are
42B is more like a mature.
megakaryocytic.
Yeah. Okay.
Sorry, is it like megakaryocytic?
Yeah, it is a megakaryocytic marker, and also 42B is
42.
expressed more in the mature platelets and not in the blasts.
Mm-hmm.
So these are all
Okay.
sticking, right? Sticking.
Yeah, yeah,
platelets.
these are all sticking.
Yeah,
cells.
that's that, because you showed a case before in which they were very high and like discrete.
Right, yeah.
And it's
That's
kind
the
of
clue.
diagonal, kind of following the same pattern.
Yeah, and that one didn't have 42B, and this one has 42B to kind of differentiate from that. Yeah. Okay.
Yeah, sure. So
Okay.
on this one, I was at like there is some abnormal T cell population which is losing its 7, and like there is a partial loss of 7 expression, partial loss of 2 expression is there. So there is abnormal, and then there is that possibly there is dendritic cell hyperplasia or something, like there is that population was there. So and then I wasn't sure about that 34, where is that, because in some of the plot it is dead negative, and in the initial plot it's forming that T shape, which I have never seen, like this kind of 34. I'm not sure if it is real, or like why is it showing like that.
Okay.
But to me, it is like, to me the two abnormal thing were T cell and then those dendritic cells.
Okay. So this 34, like you said, we did not see it in other plots. Every other plot also had 34. Like the myeloid tube had 34, and then the second myeloid tube had 34. So we decided that this is debris, and we ignored that. So what you said is right. Like that's kind of unusual. And then in the B cell tube, we don't. So we do see a blast population in which is CD45 dim and with high side scatter, and those are negative for all the B cell markers. There is some CD38, and they don't have surface CD3, but they do have 56. They might have a little bit of DIM2. They have CD7. They do have CD4. CD8 looks like there is a DIM expression of CD8 in a subset, but it's not like as positive as the background 8 positive T cells, but looks like there is some DIM CD8, and CD5 is negative. And then when we come over to this tube, all the myeloid specific markers like 117, 13, 33, they are all negative. 123, this is not like it does look like a partial dim expression, but it's not like a convincing positive expression. And no monocytic markers, they are all negative. And then when you come to this plot, they basically see like a partial 123 expression in a subset. And then even in that subset, only partial population is positive for C56. So we did think about like blastic plasmacytoid dendritic cell neoplasm based on the 123 and 4 and 56, but then like it is only partial, and a subset of it is expressing the other markers. It didn't have like a consistent expression of all 3 markers to call it that. So we did not, we just raised it in the differential, but we did not call it that. And then in this one, MPO is clearly negative because those are the background grants that are negative. So they used actually CD56 to isolate the blast, because that is the one that seems to be like really positive. And the 56 positive cells, they, like they don't have the intensity of CD3 as the background T cells. Cytoplasmic CD3, usually there is some noise on other cells other than T cells, but we call it positive only when it reaches the intensity of the background T cells, always. for cytoplasmic CD3. So we did call this as negative. And those other markers like 4, 7, and 56, we called it non-specific expression. And this one for erythroid and megakaryocytic markers, there is a small subset of this maroon population that expresses glycophorin. But again, this population also expresses all sorts of markers like 56, 7, and 38 DR. So it doesn't have like a real erythroblast phenotype overall. So that was not favored. Again, this has 4 colors: green, maroon, blue, and the purple. And so the purple color are just blasts with surrounding platelets, or some of them could be just platelets alone, because they have this bright 61 and they have 41, and they also have 42B. If they have 42B, then they are clearly platelets, they are not blasts. So that population we can ignore. And then this green population just has CD71, it doesn't have anything else. So they are just the background debris from the erythroid cells. Basically, the blue and the maroon are the population that are of interest. The blue does not have any megakaryocytic or erythroid markers. The maroon had a little bit of glycophorin, but again, the overall phenotype does not favor an erythroid differentiation. So in the end, we just called it as acute leukemia, ambiguous lineage, and then we discussed all these in the differential diagnosis, like why we think it's not PPDCN and why we think it's not erythroid, and clearly other myeloid and lymphoid markers were negative, and we did call that cytoplasmic CD3 as negative. So
Very tough case.
grade 5
Yeah,
and 6
that's a
were
very
like
tough
very
case.
challenging case. But these kind of cases, this was when I was a fellow, and we had consensus, and all attendings sat together and decided what is the diagnosis. So we don't have to panic. It's just nice to discuss,
No, we are glad we are seeing it. You see it once, like at least when we'll see next time, we will have an idea of something like that has like you have seen.
Right. Yeah.
seen
It's just
before.
to like stimulate a thought process.
Yeah.
That's the fundamental idea. But we don't have to, anything that is not straightforward, we can always ask around. So.
Yep. Thanks for bringing these cases, Rajeshwari.
No problem. My pleasure. Okay, this one, 2-week-old with trisomy 21.
I can do that.
Yeah, okay.
Yep. So in this one, there are 8% blast, and then they are 33 positive, 34 negative. Subset is 117 positive. HLA-DR is negative. Then 33 is positive, moderate, and then 15 is negative. Then 38 is moderate positive. 15 negative, 13 maybe subset positive, 11B negative. Going down. Yeah.
This is finds me out.
Okay, 71 negative, 16 negative, 14 negative, 64 negative, 14 negative. So like monocytic is gone. Then it's 11B negative. 56 is positive. So far 56 is positive on them. And then is 2 negative, 4 negative. Then is 7 is negative. 7 maybe subset is positive. 7 is positive, 2 negative, 4 negative, 8 negative. And yeah, it's 20 negative, 10 negative. So and then here they are positive for 61A. Subset is positive, 41A subset is positive, and 36 subset is positive. So it is to me so far. So it was positive for 33, 38 was positive, 13 was subset positive, 7 was positive, and 56 was positive. And then this 36, 61, 41 subset was positive. So it has some kind of maybe megakaryocytic differentiation to me. So I was thinking of an blast count is 8%. I was thinking of like those Down syndrome one,
Right.
which is transient abnormal myelophysis. So it's not like yet acute loop, but it has that phenotype.
Right. Yeah, that's what it was, and your description was right too. So I don't have anything to add, except that 56 and 7 is something that we commonly see in these cases. So this one had nice 56 and 7 expression. And other thing is like 36 is positive, but 36 is not specific for anything. It can be positive in megakaryocytic, erythroid, or monocytic lineages, but it's like nicely homogeneously positive. But this had characteristic megakaryocytic markers. So yeah, this was a TAM. It started with 20%, like on the 1 week later, and then it went down to 4%. And then after that, we lost follow-up. So I think it cleared. Okay. Case 8.
I can take if Halima is not taking, or if she's taking, I can do later.
It's okay. I can take it. I can try.
Okay. Okay. Go ahead.
And then Shweta can help out.
Okay.
So blasts are blue, and there were 6%. I think they were a tiny population. And then following that, it's red. So there are 34 positive, 33 positive, 117 dim, HLA-DR positive. Then there are 15 negative, 38 positive. And then there are 13 positive, 11 B negative. And then here there are 71 negative, 3 negative, 16 negative, 14 negative, 64 negative, and 56 negative. Then they are 2 negative, 4 negative, 7 negative, 8 negative, and then 19 and 20 negative. And then I think this one just was trying to show grams, and we have that 13 and 16 check. But what I was thinking when I saw that, I think there was a peripheral blood, and I thought that this looked abnormal for a peripheral blood, like this kind of like expression. I thought we see it more in bone marrow, so I thought that was a little abnormal. And then 11B and 16 looked abnormal to me, because it seems that they're losing some of them are losing that 16, and I felt that some of them are like expressing partial 56, which I thought was abnormal. And then there seemed to be some contamination with the monocyte, which are 14 and 16, but they're dim 14 and dim 33, I thought. So yeah, so this kind of showed to me that maybe the granulation maturation is not that normal. And then the last one was monocytes, and it was just showing 16 and 14 positive. But they are expressing like maybe a tiny amount of it is expressing 56. I know that they tried to draw the gate all the way to the left, but I thought that maybe it was partial 56.
Right.
And HLA-DR positive and 33 positive. So I thought the monocytes were a tiny like a little bit dysplastic as well. And then so then put all together, I thought, oh, I can't remember, was that the 34 was positive. So probably I thought this was an AML with some dysplastic features like an MDS.
Okay. Anybody else has anything to add?
Is this patient on any GCSF therapy or something?
Yes. Yeah, so that's basically what I wanted to show. If you remember what Akanksha showed in the initial sessions, what kind of maturation you'll see in regenerative marrows and GCSF administration. I found like a similar pattern in this, so I thought I'll share. So that's why I gave this history. It's very easy to think that these are dysplastic because the maturation is kind of, you will see 13 versus 16, you will normally see like it goes all the way to lose 13 and then it starts acquiring 16, but that's not happening here. It's only showing a mild loss of 13 and then it's picking up. So there's like, it's kind of different from what we normally see. And also in a peripheral blood, you're not expected to see all these immature forms. Only the 16 and 13 bright granulocytes should be there. All these precursors should not be there. Same with others. And also this 56 expression in granulocytes and 56 expression in monocytes is not usual. So that's why like you have to correlate with the history. The patient has a history of BALL and is currently on therapy. And I said like 10 days back, his CBC was severely pancytopenic. So they started the patient on GCSF. So now there is a marrow response. And so that usually includes left shift in beyond the stage of band. So you'll see all the left shift cells like promyelocytes, myelocytes, metamyelocytes in the circulation, and monocytes will be increased sometimes. And you can see blasts. Usually like it's 1 to 2%, but sometimes I have even seen cases with 10% blasts, and we have even asked the clinical team to order a flow cytometry just to make sure it's not the disease blast and just the GCSF blast. So this one, the patient has a history of BALL, but now the patient, the blasts are like typical normal myeloid. And I also said the patient is on consolidation because like it's, you know that the patient is on therapy and you don't think about therapy related myeloid neoplasm or anything because the patient is still, in the lymphoid process yet. So this is a GCSF effect. And this, I think in the Brentwood book, this same picture is probably there.
So they're just regenerating marrow. Okay.
Right. This is a peripheral blood with stimulated marrow. So yeah, and also regenerative marrow can show the same features.
Okay.
Yeah, it would become confusing if the patient had a history of myeloid leukemia with this kind of blast, especially in the marrow. But again, if the phenotype is normal with no aberrant expression, and if you compare with the normal, if you compare with the previous original diagnostic blast, it could be, you can identify whether they are neoplastic blasts or not.
But is it normal to see this blast in peripheral blood?
No, it's not. So that's why I'm saying like GCSF, when they administer GCSF initially after like when the peak effect is there, we can see transient blasts in the peripheral blood and they disappear. They eventually mature and disappear. Sometimes you can see a large number of blasts, rarely, because sometimes they give continuously for 4 or 5 days or 6 days. Then we sometimes see a lot more blasts than usual.
Okay.
Yeah, but we don't perform flow cytometry on those cases usually because we know clinically there is GCSF and this correlates, seeing the whole spectrum from blasts, promyelocytes, myelocytes, everything. But when there is a really large number of blasts, we want to separate from, we want to make sure there are no neoplastic blasts hidden in there. So, okay. Case 9. Case 9 was more for like couple of things. This is like a straightforward BALL, but
Is it the MRD panel for BLM?
right, yeah. So this is like the original diagnostic. This diagnostic specimen, but we run this to keep the phenotype so that we can use the same for MRD and compare the phenotype. So that's one thing I wanted to discuss, and then I wanted to discuss about this one. Does anyone have an idea what this is? What
No,
is it?
I don't think so.
Okay, so this is CRLF2, and in the new WHO, we have a category called PH-like BALL, Philadelphia chromosome-like BALL. So basically, this is a new entity that has been introduced in the recent years after they found in one study that there is a set of BALLs which does not have Philadelphia chromosome, but has the genomic map a mutation similar to what we see in Philadelphia positive BLL, and they behave similarly. So they created this group, and half of this group has tyrosine kinase mutations in ABL kinase and EPO and other things, and half of these have CRLF2 rearrangement. So this rearrangement basically approximates CRLF2 with IgG and kind of upregulates CRLF2 expression. And it's very sensitive by flow, and this rearrangement can be cryptic in normal karyotyping. Fish is sensitive, but not all places have fish, but flow is very sensitive. All cases of translocation have increased CRLF2 expression, so they can be identified by flow. So here what you see in green is the control histogram, and what we see in red is the CRLF2 expression on the blast. So then there is an overlay. So this is a negative control, and the overlay kind of overlaps. There is an overlap between the negative control and the blast, so there is no CRLF2 expression in these blasts. If there is expression, you will see the blast curve to be on the right of the negative control. So I have it somewhere, but I just couldn't find it. I tried for a while, I couldn't find it. So that's basically what this is, and it has prognostic significance. They say that this has poor prognosis, and also we do this for pediatric patients because with age there is decreased incidence of CRLF2 rearrangement. So it is usually in pediatrics and young adults who have these rearrangements, and half of the patients with CRLF2 rearrangement has mutations in JAK1 or JAK2, and they benefit from JAK inhibitors like ruxolitinib. So if they are positive for this, they go and test for those mutations. So it has some prognostic and therapeutic relevance, especially in pediatric population. So this is something I think most labs will pick up and start doing in the more and more in the future. So this is good to remember that. And for the other thing that I wanted to show is like here in the MRD, we used three tubes. One tube here that had CD19, 20, 58, 10, and then CD38, CD45, and then they used CD19 to isolate the 19 positive cells, including the blasts and the B cells, and then they used 20 and 45 to separate the B cells, and we can see 19 and 10 positive blasts, 58 are positive on the blast. So they used these markers to isolate the blasts and isolate the blast in this gate. So this one is relatively simpler, and then the second gate also had second tube also had CD19. So this one had just additional markers CD13, 33, and CD9 to see their expression. The main purpose of having two tubes was like the fluorochrome that goes with 13, 33, and 9 could not be added to this tube because the same fluorochrome was also used for 38 and I think 58 or 19, I don't exactly remember. So they had to have this second tube. But because we have CAR T cell therapy and blinatumomab targeted against CD19, that those tubes are not always reliable because in relapse in these conditions, the blast can be CD19 negative. So they had this tube which does not have CD19 at all. It has CD22, CD24, and CD66B, and then it has CD20, CD10, CD38. So what they do is like they just use create a rough B cell gate. They include everything that is positive for CD22, and they include everything that is positive for CD24. So now our granulocytes now are also positive for 24, but granulocytes are also positive for CD66B. So they use 66B to eliminate the granulocytes from this gate. So here the granulocytes are here because they are 66B and 24 positive, so that gets eliminated. So this is a rough B cell gate that includes both 22 and 24 positive cells. And then they separate hematogones and lymphoblasts and mature B cells from further working up this gate with 20 and 38. For example, the bright 20 positive cells and bright CD45 positive cells are the B cells, and then 24 is positive in the blast, but as they mature, 24 is lost, and then 22 is gained. So that's how they serially gate these cells and isolate the hematogones and lymphoblasts, and also use it to identify residual neoplasia. Just wanted to get the concept across. I don't have any plots for MRD because the reason I didn't save them was because, you know, when somebody already identifies the abnormal population and puts a color to it, we know that it is abnormal. So the real challenge is when we gate it, we have to identify that abnormal population because it will be hiding behind the hematogones or normal B cells. So that's where the real challenge is. So usually in MRD training, they give list more data. You open it in your software and you identify the population and see if that's what you're supposed to do. So we cannot do MRD in like PDFs. But I thought like just wanted to tell you how the workflow is usually. That's why I had this case.
Okay, that's great.
Thank you.
Okay, case 10. It's a 6-year-old with lymphadenopathy, hepatosplenomegaly, anemia, neutropenia, and thrombocytopenia.
I was thinking of ALPS on it, but it did not
Okay.
match the percentage which is needed for it, though. I think,
So
like,
what percentage do you need?
should be more than 5%, right? And it was
Of-
1% or something in the table below of 4 negative, 8 negative.
So we have 10%.
Oh, we do have. Okay, then okay, then it is ALPS.
Okay, so I'll let you know what ALPS is. ALPS is autoimmune lymphoproliferative syndrome. So it manifests with pancytopenia and organomegaly. Basically, there will be a mutation in FAS ligand and receptor. So the lymphocytes go into a killing spree. They kill the RBCs, neutrophils, and platelets. So they manifest with pancytopenia, and there is proliferation of these abnormal lymphocytes in the lymph node and reticular organs. So they have this organomegaly. And it's common in pediatric patients, and peripheral blood is a very sensitive specimen for identifying these cells more than the lymph nodes actually. And what we are supposed to see is a double negative population, 4 and 8 double negative T cell population. That's what we need to see. And they should be more than 1% of all cells or 2.5% of the CD3 positive T cells. So if you see here, this orange population, or sorry, the yellow population that is positive for CD3, they have variable 7, they're negative for 56 and 16. They're positive for 2, and they are negative for 4 and negative for 10. And then in the background, we see the normal 4 positive, and actually you'll see here 8 positive T cells. But this yellow population these are T cells, but they are negative for 4 and 8. They have 5 to like 7 in the normal spectrum and everything. So then further, we have to make sure that these double negative T cells are all alpha beta, because that's what we need for ALPS. They are all alpha beta T cells. So here we have alpha beta and gamma delta. Normally, peripheral blood T cells are mostly alpha beta T cells. So as long as they are polyclonal, you don't have to worry about it. So we see a big population of alpha beta and a small population of gamma delta. And the alpha beta cells are like, you see both the red and green here, it's kind of hiding. We see in alpha beta, we see both the 4 positive and 8 positive cells. You can see here, they're both alpha beta positive. And there is a small population of gamma delta. The reason I told you to look at the table was because that yellowish orange population is kind of in the back of this here. It's negative, double negative, and alpha beta positive. So the picture itself doesn't make it easy for us to recognize that population. They should have taken this out and showed us clearly, but they did not do that. But the table helps in that. So the yellowish orange is here and the background is green, and it's so hard to identify those. But if you see in the table, the 4-8 double negative T cells are 10% of all cells. And if you see the total alpha beta, I mean, of the 10%, only 0.2 are gamma delta, rest are all alpha beta. So this was ALPS. So in ALPS, you need a 4-8 double negative T cell population that are alpha beta receptor positive, basically. And these patients are also prone for developing lymphoma in the future. So yeah, okay, that's what this was. Any questions?
I just have a question. It's really basic and it's like very first, like that 13 versus 33, if you go to any of those myeloid plots, I see that Nike sign is, I have memorized kind of, but like you people are always like, it should be that high and that low. Where exactly is it? Can you just tell that part again? Just
The
where
Nike
those
swoosh.
granular site, like just go to granular site where the granular sites are there in any
Okay,
of the
I don't
schools.
think I have a good one.
No, we do had the one here.
Not a good one today, but I might
Oh,
have
okay.
one from yesterday. I mean the previous days.
Because I think what I'm missing is whenever I see that sign, I think it's okay. But then, as Halima said, it was lower on that plot, and I didn't pick that. So I just wanted to see like
Okay, let's
what
see
I'm
in this
missing on
one,
it.
in the CML plot. So you see here.
Okay, got it.
So
Okay, now I
this
get it.
where like bright 13, totally
Oh.
negative 16. That's where promyelocytes sit.
Okay, got it.
And then you would see a subset that has completely lost 13. They're negative for 13 and 16. That's where the myelocytes are. And then the metamyelocytes gain both, and then the neutrophils have both. Yeah.
Got it. Got it.
Yeah.
Thank
So
you.
that's
so much.
like it
Thank
should
you.
start at the edge of here and then go all the way down and go like that.
Okay. Okay.
Right.
Yeah, I forgot that it has to dip that down. Okay, got it.
Right. Yeah. And also it has to start here all the way.
Start here. Okay.
Yeah.
Sure.
Okay. All right. Okay,
What's the
guys.
schedule for
Huh?
tomorrow? What is for tomorrow?
I'm not sure, Akanksha, if she said she's gonna be on and off today. I'm not sure if she's here.
I'm here. I
Okay,
think
she will
we
tell.
are done. I think we are done. I mean, I don't think that we are going to do. We had like 4 chapters from Brentwood that were remaining. I might do them in the morning, around 10ish. But at this time, around 4ish, I won't be having time to do that because my kid would come from school. But I guess that's it. I mean, I think we are done with this.
Okay.
Is that a shocker? We are done with our sessions. This is it for our flow cytometry sessions.
Okay, good. Thank you. Thank you so much.
I should actually especially thank Shweta, Halima, and Priya, because like without you guys, there would be nobody speaking.
Yeah, and you
I'm
guys are
telling
all
you, the
very
people
good.
are scared of flow. That's why they're not speaking. They are listening to these sessions afterwards.
So I thought this was a great opportunity. I've learned a lot, and you know we're like our like the hospital I work with is not a downtown hospital. It's a community hospital, so we don't see sometimes much weird cases. So this was a great opportunity for sure. Thank you.
And I also like this.
Yes, indeed. Great effort to start the flow cytometry session and also taking the effort to read through the chapters, and also bringing the discussion on all the common entities, especially to brush so that they are not missed, and then also highlighting the vague ones that could be easily missed. So great effort from everyone. Thanks a lot.
Thank you, guys.
Thank you. Thank you so much.
Yeah, I'm sure Akanksha will come up with some other idea to have another group meeting.
I know. Yeah, I will. Maybe another couple of months, because I'll take couple of months to settle down in my new job. But as soon as I'm settled in my new job, I would be like, okay, let's do this.
Okay, Akanksha, I'm just curious. So when you did your WHO book club, were you also at that time with your husband, or he was in a different place that time also?
No, that time he was in a different place, and at that moment it was COVID plus it was in New York. So New York was very badly hit with COVID at that time, if you remember. So we were all at home. We were working from home, and we were signing out from home, everything.
Okay,
so
okay.
we kind of had time in hand. It was like perfect scenario. We used that time to write the book. We used that time to do the WHO book club. And that was perfect, actually.
Yeah, okay. Because I feel like last year my husband was also in a different city. I felt like last year I had more time, and this year I don't have any time.
Yeah, agree with that. Like, agree with that. This year I have had much less time than the last year. And that was because of COVID, I believe.
Okay.
No, I
Yeah.
think it's the husband. When he's with you, you have less time.
I completely agree. I mean, I'm busy. Yeah.
Ask
Yeah.
me. I'm the victim.
Yeah.
All right, you guys, we'll miss you.
Yeah.
Thank
We
you,
should find
Akansha.
something to meet
Thank you.
again.
Thank you so
Yeah.
much.
Thank you very
But
much.
I
Yeah,
promise
we'll miss
I'll
this
come up with something
discussions.
else. I promise
you.
I'll come up with something else, and we will be meeting together again.
Yeah,
Okay.
sure.
Awesome.
Yeah.
Awesome.
Sure.
Thank
Bye
you.
bye.
You
Bye
guys
bye.
keep in touch in the group.
Thank
Bye-bye.
you.
Yeah.
Take care. Keep in
Thank you.
touch.
Thank you.
Bye.
Thanks.
Thank
Bye
you.
bye.
You
Seriously.
guys.
Bye bye.